Okay, so this is the next day of neurology. Okay, so I'm gonna pull up the where are our notes? First aid general principles. Okay, here we go. Not general principles. We want first aid organ systems. No. Oh, right. Okay. Organ systems. Okay, here we go. And then let's pop out the chat. Okay. Okay. So we're going to start from where I stopped, which is reading seizures, and hopefully I can get through at least I can get through all the way to at least the farm section. I don't think I want to do the farm section, but okay, so 507, page 507, and the page that seizures starts on is, oh, there's going to be a lot to read. Okay. Seizures start at here, okay, which is page 488. Okay. Bismillahirrahmanirrahim. Okay, so now we're going to talk about seizures. Seizures are characterized by focal or global neuronal hyperactivity, which often causes a sudden change in behavior, but may also be subclinical. This change manifests differently depending on the region of the brain affected. Let me pause for a second. I might as well just share some people I know a study stream, because why not? Okay. 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 So now let's start reading. Okay. So seizures are characterized by focal or global neuronal hyperactivity, which often causes a sudden change in behavior, but may also be subclinical. This change manifests differently depending on the region of the brain affected. So you can have cerebral edema. This causes an increase in intracranial pressure, ICP, and commonly occurs 2 to 4 days post-infarction. Edema may be cytotoxic, which is secondary to hypoxia and hyponatremia. It may be vasogenic, which is increased vascular permeability, secondary to inflammation, metastasis, trauma, respiratory acidosis, leading to space-occupying lesions that cause mass effect on the underlying brain tissue. And then you can also have cerebral edema present as classic signs of increased intracranial pressure, like papilledema, swelling of the optic disc, projectile vomiting, sinus bradycardia, hypertension, and decreased level of consciousness. Treatment is to address the underlying cause if possible and manage the ICP, raise the head of the bed, mannitol, hypertonic solution, hypertonic saline, hyperventilation, sedatives, paralytics, external ventricular drainage, and shunts. And their prognosis, there's a potential for herniation, which carries a poor prognosis. Key fact, generalized convulsive status epilepticus, 5 or more minutes of continuous seizure activity, or incomplete recovery of consciousness between 2 or more discrete seizures, typically tonic-clonic, characterized by sudden loss of consciousness, tonic contraction and loss of postural muscle tone, followed by rhythmic contractions in all 4 limbs. Immediate treatment with fast-acting benzodiazepines, like lorazepam, is needed to stop seizures. Phenytoin is also used to reduce the risk of another epileptic attack. Phenobarbital and then phenobarbital and then pentobarbital or general anesthetics like propofol may be needed to fully abort the seizure. Okay, so this is for generalized convulsive status epilepticus, which again is 5 or more minutes of continuous seizure activity or incomplete recovery of consciousness between 2 or more discrete seizures. Okay, let's continue on. Okay, here's types of seizures chart. Should we read it? Yeah, we can read the types of seizures chart. Okay. Bismillahirrahmanirrahim. So type 1 is partial, one area of the brain. Presentation, simple, consciousness intact with motor, sensory, autonomic, and psychic components. Complex is components of simple but with alteration of consciousness. Treatment / prognosis is carbamazepine. For simple seizure, this is carbamazepine, valproic acid, gabapentin, lamotrigine, topiramate, phenobarbital, tiagabine, vigabatrin, and levetiracetam, and it can secondarily generalize. And then for complex ones, you can use the same drugs I just mentioned, especially oxcarbazepine, okay? And its etiology by age is children is genetic, infection, trauma, congenital or metabolic. Adults are tumors, trauma, stroke, or infection. And elderly, stroke, tumors, trauma, metabolic, and infection. Okay, so note how elderly has increased stroke risk compared to adults. Okay, generalized. So this is like seizure everywhere in your brain, not generalized, or I guess partial, localized to some area. So you can have absent seizures, also known as petit mal. It's 3 Hertz, 2 years old to puberty with blank stare, no post-ictal conclusion. So for absence ones, you can use ethosuximide and valproic acid to treat them. Okay, myoclonic seizures, these are quick repetitive jerks. To treat them, you can use valproic acid. Tonic-clonic, also known as grand mal, this is a tonic phase characterized by limb stiffening, followed by a clonic phase characterized by rhythmic jerking. Post-ictal phase is characterized by lethargy and disorientation. So treatment for this for tonic-clonic is phenobarbital, phenytoin, carbamazepine, only for secondary generalized but not primary, valproic acid, topiramate, lamotrigine, and gabapentin. And then tonic is stiffening and atonic is drop seizures. Note, do not treat absent seizures with sodium channel blockers as they worsen the seizure. Valproic acid should be avoided in pregnancy as it inhibits folate reabsorption, increasing the risk of neural tube defects, and of course we don't want neural tube defects. Okay, cerebral contusion. This is permanent damage to small blood vessels in the parenchyma of the brain, typically due to acceleration-deceleration injuries. Presentation is coup at the site of impact and contra coup, which is the opposite side of impact, usually at the tips of the frontal and temporal lobes. Injuries. Anyways, thanks. I really appreciate all my supporters coming out to watch. Helps me study too. So anyways, diagnosis for cerebral contusion is either CT or MRI. Treatment is directed at managing sequelae or lowering elevated intracranial pressure. Specific measures to lower intracranial pressure include elevating head of bed to 30-degree incline, optimize venous drainage. You can head midline, neck neutral, ensure neck brace is not constricting, hyperosmolar agents, mannitol and hypertonic saline, hyperventilation, reduces partial pressure of carbon dioxide in arterial blood, resulting in cerebral vasoconstriction and reduced ICP. And I'm just going to ask you, hope you are doing well. Okay. Key fact, patients with head trauma are often temporarily hyperventilated to produce respiratory alkalosis, which causes cerebral vessel... Oh my gosh, let me reread this. Patients with head trauma are often temporarily hyperventilated to produce respiratory alkalosis, which causes cerebral vessel constriction by decreasing partial pressure of carbon dioxide. This decreases cerebral blood volume and vessel permeability, thereby reducing risk of cerebral edema. Note that respiratory acidosis causes vasodilation and increased vessel permeability, which enhances cerebral edema. Now you can have the Cushing triad. This is bradycardia plus respiratory depression plus hypertension increased secondarily to intracranial pressure, secondary to increased intracranial pressure. So again, bradycardia plus respiratory depression plus hypertension. It's also called the Cushing reflex or the Cushing response. Both arms of the autonomic system are activated. The sympathetic nervous system drives more blood centrally with concomitant activation of baroreceptors, parasympathetic, to reflexively decrease the heart rate. Surgical treatment is rare with the exception of severe cases, and prognosis may progress to herniation as edema develops. This again is cerebral contusion, like you hit your head and you hit it and then it also bounced back and hit it. Okay, primary brain neoplasms. Neoplasms may result in mass effect, which prevents seizures, dementia, focal lesions, increased ICP, which is headache worse in the morning, nausea, vomiting, and bradycardia. With hypertension, primary brain tumors seldom undergo metastasis. Most adult primary tumors are supratentorial, whereas the majority of childhood primary tumors are infratentorial. Tentorium, I think, again, was... actually, I don't remember what tentorial was. What is supratentorial? above the tentorium cerebri. Okay, I need to see. Oh, here, perfect. Okay. So primary brain tumors seldom undergo metastasis. Assalamu alaikum. Primary brain tumors seldom undergo metastasis. Guys, don't get brain tumors. If you watch too much anime, you can get brain tumors. Most adult primary tumors are supratentorial, whereas majority of childhood primary tumors are infratentorial. Half of adult brain tumors are metastases from, in order of decreasing prevalence, lung, breast, skin, kidney, GI tract, and thyroid cancer. Metastatic brain lesions present as multiple spherical lesions at the gray-white junction that frequently bleed, not breed. Shukran. Okay. Pituitary adenomas are benign neoplasms that arise from one of the 5 anterior pituitary cell types and are generally monoclonic. Prolactin secreting adenoma. Prolactinoma is the most common form. Diagnosis with MRI and endocrine studies. Transsphenoidal surgery confirms the results of clinical and lab studies. Treatment is transsphenoidal surgery, normalization of excess pituitary secretion, dopamine agonists, bromocriptine or cabergoline for prolactinomas. Hormone replacement may be necessary depending on the patient's age, sex, and presentation. No, you're not supposed to take notes. Well, I mean, I'll take notes later. First, I need to read this stuff, and then I will look at charts that are important, and I'll try to copy it down in my mind and stuff. But that's step 2. First step is reading. And if I read out loud, I can listen to my recording later, hopefully, inshallah, and maybe then I can benefit from that. If I listen to it while I drive or walk or whatever. Prognosis: if the lesion is resectable, so this again was pituitary adenoma, with preservation of pituitary function, then prognosis is good. Key fact: astrocytes can be visualized by staining for glial fibrillary acidic protein, GFAP, an intermediate filament. So here's location of adult and childhood primary brain neoplasms. Okay, so these are supratentorial, and then these are infratentorial. So supratentorial, I guess it's more up in the brain. Here's your meningiomas, I guess, are more posterior. Okay, and then this is your front of your body. So pilocytic astrocytoma, oligodendroglioma, and glioblastoma multiforme are all more anterior. And then, interesting. We can have schwannomas and ependymomas and mediuloblastomas and hemangioblastomas and craniopharyngiomas and pituitary adenoma. This makes sense. Craniopharyngioma is mostly a childhood tumor. Okay. Ooh, this is a big chart. Oh, wow. Okay, yeah, let's read it. Okay. So these are primary brain neoplasms. Okay, adult peak incidence. So type glioblastoma multiforme. It presents as pseudopalisading tumor cells border central cell areas of necrosis and hemorrhage with ring-enhancing appearance and imaging found in cerebral hemispheres, frontal lobes most commonly, and may cross corpus callosum, butterfly glioma, ill-defined mass, most common primary brain tumor, high-grade astrocytoma that stains positive for GFAP. Prognosis/treatment is less than 1 year life expectancy, poor prognosis, combination of surgical resection, chemotherapy, and radiation. Hemangioblastoma is associated with von Hippel-Lindau syndrome. When found with retinal angiomas, foamy cells and high vascularity are characteristic, may produce erythropoietin, causing secondary polycythemia, mesodermal origin, and treatment is resection. Meningioma is an extraaxial tumor external to brain parenchyma arising from meningeal arachnoid cells that occurs in convexities of hemispheres and parasagittal region, often asymptomatic but may present with seizures or focal neurologic deficits. Symptoms arise from mass effect rather than infiltration of brain parenchyma. Spindle cells concentrically arranged in a whorled pattern. Samoma bodies, which are laminated calcifications. In its most common benign primary central nervous system tumor in adults, it's a common cause of new onset focal seizures, and treatment is surgical resection for an meningioma. Next, oligodendroglioma. This is a slow-growing tumor, most often in white matter of frontal lobes, fried egg cells with round nuclei and clear cytoplasm. Chicken wire capillary pattern, often calcified, and treatment is also surgical resection. Pinealoma is a 50 30% are germinomas that occur more often in males, less than 30-year-olds, with symptoms similar to pure pineal gland tumor without melatonin abnormalities. Pineal gland tumors compress the superior colliculus, causing Parinod syndrome, which is vertical gaze palsy, most prominently of the upward direction, pretectal area, and cerebral aqueduct. Obstructive hydrocephalus also interrupt melatonin production, leading to disruption of circadian rhythm and insomnia, may calcify with age, and precocious puberty. Treatment is also surgical resection. Schwannoma neurofibroma, third most common primary brain tumor, benign Schwann cell origin, stain positive for S100, most commonly localized to cranial nerve 8 at the cerebellopontine angle. Vestibular schwannoma may arise from any spinal root or cranial nerve except 1 and 2, which are myelinated by oligodendrocytes instead of Schwann cells. So densely uniformly enhancing on MRI, manifest with progressive unilateral tinnitus, hearing loss, ataxia with positive Romberg sign because localized at the cerebellopontine angle, and commonly occurs in neurofibromatosis type 2. Treatment is surgical resection. It may preserve hearing if small and prevent compression of cerebellum, pons, and facial nerve. Patient usually deaf at presentation. It's also called acoustic neuroma, I believe. Schwannoma, aka schwannoma neurofibroma. Okay. Continuing on, these are childhood peak incidence tumors. So craniopharyngioma is most common childhood supratentorial tumor, benign, derived from remnants of Rothke pouch, ectoderm resembling tooth enamel, distinguished from pituitary adenoma by histology, nests of uniform granular cells, present with growth failure, papilledema, compression of pituitary stalk leads to hypopituitarianism, whereas compression of optic chiasm leads to bitemporal hemianopsia, which we already knew from we did vision yesterday. Resection through is treatment, although recurrence is common. Okay. Continuing on with childhood peak incidence tumors, we have ependymal cell tumors. Ependymal cell tumors are most commonly found in the fourth ventricle, characteristic perivascular pseudorosettes. Ependymal cells around small vessels, rod-shaped blepharoplasts. These are basal ciliary bodies found near nucleus, can cause hydrocephalus, nausea, vomiting, nuchal rigidity, increased intracranial pressure. Treatment is poor prognosis. Oh, that's sad. Medulloblastoma, highly malignant tumor with rosettes or perivascular pseudorosette pattern of cells, arises in cerebellar vermis, small round blue cells, presents with ataxia, projectile vomiting, nuchal rigidity, can compress fourth ventricle leading to hydrocephalus and increased intracranial pressure, classically responsible for drop metastases to the spinal cord. It is radiosensitive and may progress to cerebellar herniation without surgery. Pilocytic astrocytoma, this is a diffusely infiltrating benign glioma, most often seen in posterior fossa cerebellar. Rosenthal fibers, eosinophilic corkscrew fibers resulting from accumulation of intermediate filament proteins specific to astrocytes, and it cysts with a mural nodule, cell stain positive for GFAP, and it has a good prognosis. This is pilocytic astrocytoma. Retinoblastoma is a malignant retinal cell tumor of childhood. It causes leukocoria, which is abnormal white pupil with loss of red pupillary reflex. Strabismus and decreased vision are common findings. Sporadic cases are generally unilateral, whereas bilateral cases suggest RB gene deletion. RB gene was the retinoblastoma gene. Two-hit hypothesis prototype. This is again retinoblastoma. Treatment is radiotherapy, cryotherapy, chemotherapy, or enucleation. Neurocutaneous disorders are usually genetic and syndromic in origin. They can present with multiple neurologic and or cutaneous signs and symptoms, which are outlined in the table. Okay, so I guess I have to read this table too. Okay, let me drink some coffee. Okay, hypersecretion. Hormone prolactin. Presentation, men have hypogonadism, infertility, impotence, decreased libido, galactorrhea, gynecomastia. So these are all pituitary adenomas, by the way. So if you have hypersecretion of prolactin, again, you're going to have in men hypogonadism, infertility, impotence, decreased libido, galactorrhea, and gynecomastia. Women are going to have, if they are premenopausal, they're going to have menstrual irregularities, oligomenorrhea or amenorrhea, decreased libido, dyspareunia, vaginal dryness, galactorrhea, anovulation, and infertility. And potential mass effects like bitemporal hemianopia, headaches in both men and women. And then treatment for prolactinomas is basically a dopamine agonist like bromocriptine or carbogoline and surgical resection. Remember, dopamine can inhibit prolactin. Next, hypersecretion of growth hormone can result in acromegaly, gigantism if prior to epiphyseal plate closure in a child. Treatment is surgical resection. ACTH overproduction is classic symptoms of Cushing disease. Again, surgical resection or radiotherapy is recommended. And then hypersecretion of TSH is classic symptoms for hyperthyroidism, and treatment is surgical resection. Hypopituitarianism. So this is compression of hypothalamic pituitary stalk leading to decreased production of other pituitary hormones, growth hormone deficiency, a lag in growth, and hypogonadotropic hypogonadism. And treatment is surgical resection followed by hormone replacement therapy because you need the child to grow. Okay. You can also have, here are the neurocutaneous disorders, okay? So some of these include ataxia telangiectasia, also known as Lewis-Barr syndrome. This is characterized by progressive cerebellar ataxia, oculocutaneous telangiectasias. These are dilated vessels in the skin and eyes. Immune deficiency, IgA deficiency, and thymic hypoplasia. Cerebellar atrophy due to Purkinje cell death, associated with increased malignancy like adenocarcinomas, lymphoma, and leukemia, increased sensitivity to ionizing radiation, and insulin-resistant diabetes mellitus. And it results in increased alpha-fetoprotein and CEA. I forget what CEA is. Etiology is autosomal recessive mutation on chromosome 11. It's a mutation of the AT-mutated gene, results in failure to repair DNA double-strand breaks and subsequent cell cycle arrests. In the absence of ATM, cells collect somatic mutations leading to malignant transformation. Okay, Sturge-Weber syndrome. This is a rare vascular disorder, small vessels commonly affected, leading to characteristic facial capillary malformation, port wine stain, nevus flammeus, a benign birthmark in the ophthalmic V1 and or maxillary V2 distribution of the trigeminal nerve on one side of the face. It may also present with intellectual disability and seizures, like epilepsy. It'll be ipsilateral, same side as facial lesion, leptomeningeal capillary venous malformation, angioma, usually of parietal and occipital lobes, which can lead to SAH, and SAH is, it's going to tell us, CA was carcinoembryogenic antigen, by the way. SAH is subarachnoid hemorrhage. Oh, wow. So it can lead to a subarachnoid hemorrhage. That's bad. And venous stasis causes tissue ischemia, resulting in intraparenchymal calcification. Early onset glaucoma due to episcleral hemangioma, blocking outflow of aqueous humor. Etiology of Sturge-Weber syndrome is an anomaly of neural crest derivative secondary to a somatic mosaic mutation of the GNAC gene. It's congenital but non-hereditary somatic. Thus, recurrence is unlikely. Okay, tuberous sclerosis complex. Tuberous sclerosis, this is really important. Apparently, tuberous sclerosis is like this rare disease that can show up on the exam. So it's characterized by multiple hamartomas of the skin and the CNS, infantile spasms, subependymal nodules, astrocyte proliferation, and subependymal giant cell tumors in periventricular area of brain. Dermatologic features include ash leaf spots, which are hypopigmented macules, shagreen patches, which is connective tissue nevi, commonly on the lower trunk, ungual fibromas and facial angiofibromas, adenoma sebaceum, flesh-covered papules in the malar region or nasolabial fold. Associated tumors include cardiac rhabdomyoma, very specific, causes mitral regurgitation, renal angiomyolipoma, intellectual disability and epilepsy. Seizures are the most common presenting feature and often refractory to medication. It is autosomal dominant with incomplete penetrance. Marked difference in phenotype among family members is due to variable expressivity, and the mutation of either the tuberous sclerosis 1 gene, which encodes the protein hamartin, or on chromosome 9, or the tuberous sclerosis 2 gene, which encodes the protein tuberin on chromosome 16. Okay. Next, so remember, tuberous sclerosis goes along with hamartomas. Next, neurofibromatosis type 1. This is a cutaneous manifestation, includes calphaeolous macules. It's hyperpigmented macules, typically 6 or more, occur in 100% of affected individuals before ages 2 years old. You'll see Lish nodules. These are pigmented iris hamartomas, and freckling in the axillary or inguinal region, also known as the crow sign. The skin tumors of NF type 1 are derived from neural crest cells, plexiform neurofibromas, which are not present in neurofibromatosis type 2, may undergo malignant transformation into MPNSTS, which is a neurofibrosarcoma involving large nerves. It's associated with optic pathway glioma and pheochromocytoma. It is an autosomal dominant 100 penetrance variable expressivity. Half of cases are sporadic. It's a mutation of the NF type 1 gene encoding neurofibromin, which is a RAS GTPase activating protein on chromosome 17. Okay, then we also have neurofibromatosis type 2. This is a central form of neurofibromatosis characterized by vestibular schwannomas, juvenile cataracts, meningiomas, ependymomas, and spinal cord schwannomas /neurilemomas of the dorsal roots. It often presents as unilateral sensory neural hearing loss and tinnitus in teens or after puberty. Unilateral vestibular schwannomas can occur sporadically, but bilateral is a disease-defining condition for neurofibromatosis type 2. It is autosomal dominant variable expressivity. It is a mutation of the neurofibromatosis type 2 gene and TSG encoding the protein Merlin, which is also called schwannomin on chromosome 22. Okay. And then we also have von Hippel-Lindau syndrome. This is characterized by angiomatosis, which is cavernous hemangiomas in skin, mucosa, and other organs. It's a variety of benign and malignant tumors, including multiple hemangioblastomas, most common manifestation of retina, brainstem, cerebellum, and spine. It's associated with clear cell renal cell carcinoma, often bilateral, pheochromocytoma, and endolymphatic sac tumors of the middle ear. Etiology, so von Hippel-Lindau syndrome is autosomal dominant. It's a deletion of TSG VHL on chromosome 3. VHL gene product inhibits the hypoxia-inducible factor 1 alpha and hypoxia-inducible factor 2 alpha, and this results in constitutive expression of the transcription factor, hypoxia-inducible factor, and activation of angiogenic growth factors. Okay, so basically the VHL gene inhibits these other transcription factors from being expressed by if VHL if VHL itself is knocked out or deleted, then you have basically always on activation of this hypoxia-inducible factor, which is going to activate some growth factors that are going to cause angiogenesis, aka like spreading in growth and spreading of blood vessels. Okay, now we're going to move on to the spinal cord and peripheral nerve lesions, okay? So you can have Brown-Séquard syndrome. This is resulting from hemisection of the spinal cord that interrupts conduction through the lateral corticospinal tract, which is a motor tract, lateral spinothalamic tract, which is pain and temperature sensation, and dorsal columns, which is proprioception and tactile sensation. Okay, nerves that run from the motor cortex to the spinal cord are referred to as upper motor neurons. Nerves that run from the anterior horn of the spinal cord to the periphery are referred to as lower motor neurons. Okay, presentation, it's ipsilateral upper motor neuron signs below the lesion for the cortical spinal tract. It's ipsilateral loss of tactile, vibration, and proprioception at and below the region. At and below the lesion. It's going to be contralateral loss of pain and temperature below the lesion because of the crossing fibers of the lateral spinothalamic tract. And it's going to be ipsilateral loss of pain and temperature a few levels above and below the lesion. And you're going to have lower motor neuron signs at the level of the lesion. And if the lesion is above T1, the patient may present with Horner syndrome, which Horner syndrome again is ptosis, meiosis, and anhidrosis. Okay, and do you diagnose via history and physical exam? So then mnemonic is Samoma bodies are associated with papillary adenocarcinoma of the thyroid, papillary serous cystadenocarcinoma of the ovary, meningioma, and mesothelioma. Key fact, meningiomas are associated with neurofibromatosis. Bilateral schwannomas are almost always caused by neurofibromatosis type 2. And ependymoma arises in the cauda equina in adults. Okay? And here's some comparison of what's the difference between upper motor neuron and lower motor neuron signs. So basically, Upper motor neuron signs, you're going to have weakness in both upper motor neuron and lower motor neuron signs. However, upper motor neuron signs is basically the muscle is going to be atrophied and there's going to be fasciculation. On the other hand, upper motor neuron signs is no atrophy and no fasciculation, while lower motor neuron signs is atrophy and is fasciculation. Now, why does this happen? Basically, if you knock out a lower motor neuron, you're going to cause the muscles to start fasciculating and they're going to get atrophied as a result. But upper motor neurons, actually, if you inhibit them, then basically you're going to get flaccid paralysis. Because basically there's nothing from the motor cortex going to tell the lower motor neurons what to do. So they're just not activated. But if you do have the case that the upper motor neurons are working, but the lower motor neurons are not working, then you're basically going to have these muscle fasciculations. Okay? So in upper motor neuron signs, you're going to have increased reflexes, but in lower motor neuron signs, you're going to have decreased reflexes. In upper motor neurons, you're going to have increased tone. In lower motor neurons, you're going to have decreased tone. And the Babinski sign is positive in upper motor neuron, okay? Actually, I think upper motor neuron might be spastic paralysis and lower motor neuron might be flaccid paralysis, now that I think of it. Let me actually, let's go to first aid. Upper motor neuron. Maybe I can go to the specific section. Let's see. No. This is actually, I should read through this also. This is gonna be good. Do we have a diagram of the neurons at all? Okay, so lower motor neuron is everything lowered. Less muscle mass, less muscle tone, less reflexes, downgoing toes. Upper motor neuron, everything up. Tone, distal, DTRs, and toes. So fasciculations equals muscle twitching, and positive Babinski is normal in infants. Okay. Cool. This is actually really, really good. Wow. Will I have enough time to read all this? Oh. I should just look at the charts for this one. Okay. Continuing on back to this. Okay. Let me see where I'm at. Let's see. Okay, upper extremity nerve injury. So again, lower motor neuron, everything is lowered. Upper motor neuron, think like basically the opposite of that, and you're not going to have fasciculations and you're not going to have atrophy. Okay, let's talk about upper extremity nerve injuries. So if you have a radial nerve injury, so C5 to C8, this is going to be at the shaft of the humerus, leading to loss of triceps brachii, brachioradialis, and extensor carpi radialis, decreased grip strength due to loss of wrist extensors. So its deficits in sensation include posterior brachial cutaneous branch, loss of sensation over the posterior arm / forearm and dorsal hand. Okay, next, median, which is median nerve problems, which is median nerve is C5 to T1. You're going to have supracondylar region of humerus, leaving arm muscle fusion intact with impaired forearm pronation, wrist flexion with ulnar deviation, finger flexion, thumb abduction, and apposition thenar atrophy. This is going to result in loss of sensation over the lateral palm, thumb, and lateral 2.5 fingers and thumbnail bed. You can have also with the median nerve, you can have carpal tunnel syndrome, which is a repetitive use injury. This passes through the pronator arteries under flexor retinaculum in the carpal tunnel. You can also have slashing the wrist. This causes loss of thenar muscle innervation, so all thumb movement is lost except for adduction, which is ulnar. And then you can also have so this is also under median nerve injury. So again, all thumb movement is lost except for adduction, which is an ulnar nerve innervated thing. Okay, so it's going to be the Tinel sign. You're going to have shock-like pain when tapped lightly on the palmar side of the wrist, and the Phelan sign, which is a wrist inflection, reproduces painful symptoms. Okay, you can also have an ulnar nerve injury, which ulnar nerve has nerve roots C8 to T1. So this is going to be the medial epicondyle, causing impaired wrist flexion, which is radial deviation, and adduction, thumb adduction, adductor pollicis, flexion of the medial two fingers, claw hand deformity, and wasting of the hypothenar eminence and PAD/DAB interosseous muscles. Okay, it's going to be loss of sensation over the medial palm and medial 1.5 fingers. It passes through the carpi ulnaris at elbow, and it passes between the medial epicondyle at the two heads of the flexor carpi ulnaris. Okay, axillary nerve injuries. Axillary nerve has roots C5 through C6. This is going to be a surgical neck of the humerus or anterior shoulder dislocation. It causes loss of deltoid action, so it's failure to abduct the arm greater than 15 degrees. Remember, I think the supraspinatus is the one that does it from 0 to 15, and then after that you use your deltoids. So this axillary nerve problem is going to manifest as loss of sensation over deltoid muscle on physical exam and a palpable depression under the acromion. Okay, and then you can also have a musculocutaneous nerve injury, which is also C5 through C6 nerve roots. This is loss of function of coracobrachialis, biceps, and brachialis muscles, along with decreased supination. It's going to have passes through the coracobrachialis and continues as lateral cutaneous nerve of forearm below elbow. So the PAD-DAB mnemonic is basically palmar adducts, dorsal abducts. So the palmar adducts and the dorsal abducts. Okay, so that's for those muscles. Okay, continuing on, so you can also have lower extremity nerve injuries. So the common peroneal nerve, which is L4 through S2, it divides into the superficial and deep branches at the neck of the fibula. This site of injury, so if it is in the deep peroneal, it innervates the muscles of the anterior leg compartment. So you'll have loss of foot dorsiflexion, causing foot drop and steppage gait. So deficits in sensation / course is the anterior compartment syndrome, results from increased pressure that causes compression of the deep peroneal nerve and vasculature, causing foot drop and weak dorsal pedis pulse. And deep peroneal is the first web space. Okay. Superficial peroneal injury, it innervates the lateral leg compartment muscles, so you're going to have loss of foot eversion. So the superficial peroneal is the dorsal surface of the foot except the first web space. So that's what it does for sensation. Okay, so tibial is L4 through S3. It courses posterior to the medial malleolus. So the tibial nerve innervates the posterior compartment of the thigh and the leg. Baker cyst, proximal lesion, or tarsal tunnel syndrome, distal lesion, loss of foot plantar flexion, and deficits in sensation include the plantar surface of the foot. So plantar sensation loss is tibial. Dorsal surface of foot loss is sensation loss is superficial peroneal. Femoral nerve is L3 to L4, and it's loss of, so if you have an injury in it, you're going to have loss of knee extension / knee jerk, and you're also going to have paresthesias of the anterior / medial thigh and medial leg. And the obturator nerve is also L2 through L4, and it exits through the obturator canal to enter the thigh, and it is loss of hip adduction, and you're also going to have paresthesias of the anterior / medial thigh and medial leg. Oh wow, and then we have this nice diagram of the brachial plexus and the associated presentation of lesions. I don't remember this for a while. Trunks, divisions, cords, branches. Yeah, I'm gonna have to be able to do this one again. Let's just read it. So a diagram of the brachial plexus and association of associated presentation of lesions. So you're gonna have, so if you have one here at the upper branch, at the upper trunk, coming from C5 and C6, you're going to have waiter tip or palsy. Number 2 is at the lower trunk, and you'll have claw hand, also called Klumpke palsy. Number 3 right here of the posterior cord is going to be wrist drop. Number 4 is going to cause, long thoracic nerve injury will cause winged scapula. Number 5 is, so this is basically the posterior cord is going to split axillary and go, I guess, to the muscular cutaneous nerve. Oh, no, it's going to, it becomes the axillary nerve. I'm so silly. So this is gonna be, number 5 is deltoid paralysis. Okay, but also it can be, the posterior cord can also become the radial nerve. This is going to be Saturday night palsy, wrist drop. And remember, radial is extensors. Okay, and then median. Muscular cutaneous, which is up here. You're going to have difficulty flexing the elbow and variable sensory loss if you have damage there. And then number 8 is the median nerve, which is flexors. You're going to have decreased thumb function. You're going to have the Pope blessing. And then ulnar is number 9 right here, intrinsic muscles of hand and claw hand. Okay. Symptomatic, Randy Travis drinks cold beer. Proximal to distal, its roots, trunks, divisions, cords, branches. Okay. Flashback, primary CNS lymphoma is associated with AIDS. Epstein-Barr virus mediated B-cell lymphoma is the most common cerebral tumor in AIDS patients. MRI showing a single ring-enhancing lesion suggests this diagnosis, although toxoplasmosis, more often multiple lesions, must be ruled out. Key fact, central nervous system lymphomas usually result from metastasis of high-grade non-Hodgkin lymphoma of B-cell origin. Flashback, in contrast to craniopharyngiomas, which arise from the remnant of the Roth-K pouch and create symptoms by interruption of the infundibulum connecting the hypothalamus to the pituitary. Pituitary adenomas arise from cells within the pituitary gland itself, with symptoms resulting from a combination of aberrant tumor cell hormone secretion and mass effect. Key fact, subependymal giant cell astrocytoma is pathognomic for tuberous sclerosis, also with cardiac myomas and renal angiomyolipomas. And key fact, familial syndromes associated with pituitary adenomas include multiple endocrine neoplasia, MEN1, McCune-Albright syndrome, and familial acromegaly. Okay, and so treatment of, what are we even looking at? Treatment of Brown-Séquard syndrome. Wow. This is early treatment with high-dose steroids. Steroids have shown benefit, as have physical therapy and surgery. Prognosis of Brown-Séquard syndrome is poor. It depends on the cause of the syndrome, which is either trauma, infection, or disc herniation. Okay, poliomyelitis is a destruction of the anterior horn of the spinal cord. Occurs secondary to fecal oral infection by poliovirus, which is a coronavirus, leading to lower motor neuron destruction. Poliovirus replicates in the oropharynx and small intestine before spreading through the bloodstream to the CNS. It presents as headache, fever, nausea, abdominal pain, and sore throat. Characterize the acute infections. Signs of lower motor neuron lesion include muscle atrophy, flaccid paralysis, and hyporeflexia with preserved sensation. Diagnosis is CSF with lymphocytic pleocytosis and slight elevation of protein. Virus is recovered from stool or the throat. Treatment is prevention with a vaccine. Salk inactive parenteral vaccine. Oral Slabin vaccine carries small risk of disease but confers mucosal immunity in contrast to inactive vaccine. Bed rest decreases the incidence of paralysis. Intensive care is needed if respiratory muscle weakness occurs. There's a high mortality rate if bulbar involvement. Persistent muscle weakness may develop years after acute infection. Okay, and this was all for poliomyelitis. It's lower motor neuron destruction, basically. Tabes dorsalis, also known as tertiary syphilis. This is degeneration of the dorsal roots and columns, mainly in lumbosacral, that develops 15 to 20 years after the onset of Treponema pallidum infection. Primarily affects the fasciculi gracilis bilaterally. So bilateral impaired proprioception, positive Romberg sign, and sensation leading to progressive sensory ataxia, paresthesias, shooting pains, Argyll-Robertson pupils, accommodate but do not react to light, absence of deep tendon reflexes, purely sensory deficit, muscular power is retained, associated with Charcot joints, which is insensitivity to pain in the joint, leading to increased susceptibility to joint injury. Diagnosis is clinical and CSF analysis. So you're going to have pleocytosis, which is increased white blood count. You're going to have increased protein concentration and or VDRL reactivity. Note, venereal disease research laboratory VDRL test may be positive in autoimmune diseases, mononucleus, or hepatitis. So follow with specific treponemal tests such as fluorescent treponemal antibody absorption, FTA-ABS, or microhemagglutination serology to confirm. You treat syphilis, tertiary syphilis with penicillin, and you should treat the symptoms. Prognosis: if untreated, it may progress to paralysis, blindness, and dementia. Residual symptoms may persist after treatment. Mnemonic: lower motor neuron lesion is everything lowered, so muscle mass lower, tone lower, reflexes, downgoing toes equals negative Babinski sign. Upper motor neuron lesion is everything up, tone up, reflexes up, and upgoing toes. It's a positive Babinski sign. Okay. Key fact: diabetic polyradiculopathy mimics tabes dorsalis. Key fact: the sciatic nerve, which is L4 through S3, emerges at the midpoint between the greater trochanter and the ischial tuberosity, then branches into the tibial and common peroneal nerves at the short head of the biceps femoris. All gluteal injections should target the superolateral quadrant to avoid damage to the gluteal nerves and sciatic nerve, the superomedial quadrant. Key fact: vitamin B12 deficiency may also be caused by pernicious anemia, which is an autoimmune disorder that involves antibodies against intrinsic factor or gastric parietal cells, or both. In addition to subacute combined degeneration, vitamin B12 deficiency can result in megaloblastic anemia, which are large abnormal RBCs. Flashback: methylated B12 methylcobalamin is an essential cofactor for the conversion of homocysteine to methionine, so deficiency results in impairment of DNA synthesis. A high level of homocysteine is a risk factor for cardiovascular disease. Okay, so subacute combined degeneration is a vitamin B12 deficiency. It's most commonly resulting from pernicious anemia, which leads to functional B12 deficiency and results in buildup of methylmalonyl coenzyme A, CoA, and its precursor propionyl CoA. Propionyl CoA displaces succinyl CoA in fatty acid synthesis, resulting in anomalous insertion of odd-chain fatty acids into lipids such as myelin. Demyelination of the dorsal columns and lateral corticospinal tract may occur with patients presenting with proprioceptive and motor symptoms. So presentation as dementia, ataxic gait, demyelinated spinocerebellar tract, symmetrical spastic paresis, demyelinated corticospinal tract leads to upper motor neuron loss, and impaired position and vibration sense, bilateral demyelination of dorsal columns. Wow. So diagnosis is a serum B12. You can do an MRI and the Schilling test. You should give the Schilling test is that you give the patient radio-labeled B12 plus intramuscular injection of unlabeled B12 and measure urine radio-labeled B12, which should be high. If the first test is abnormal, give radio B12 and intrinsic factor to determine if a malabsorption problem exists, and then measure the urine radiation B12. If still no radiation B12 in urine, give radiation B12 and antibiotics to rule out bacterial overgrowth and measure urine radiation B12. If still no radiation B12 in urine, then give radiation B12 and pancreatic enzymes to rule out pancreatitis and then measure urine radiation B12. Okay, and here's a question, or let me go to treatment first. So treatment for subacute combined degeneration is vitamin B12 supplements, oral or intramuscular. And prognosis is the best prognosis is in those with gait disturbance less than 3 months prior to commencement of treatment. Question: if a 63-year-old man with chronic alcoholism presents with increased forgetfulness and confusion and a serum sodium level of 115 after starting IV hypertonic saline to correct hyponatremia, he develops flaccid quadriplegia, what is responsible? I think basically you overcorrected too fast, and he's gonna die. Basically, he has osmotic demyelination syndrome, also known as central pontine myelinolysis. It occurs after rapid correction of chronic hyponatremia, which causes water to move out of brain cells in the white matter of the pons, leading to demyelination. Okay, next, syringomyelia. This is an enlargement of the central canal of the spinal cord, leading to damage of the STT fibers as they cross the anterior commissure. So STT fibers, I think, is the spinothalamic tract fibers as they cross in the anterior commissure. So it's again enlargement of the central canal of the spinal cord. It may also erode the anterior horn, resulting in lower motor neuron defects. Often presents in patients with Arnold-Chiari type 2 malformation, which is herniation of cerebellar vermis through the foramen magnum, causing hydrocephalus, meningomyelocele, and syringomyelia. Okay. Presentation is bilateral loss of pain and temperature sensation in the upper extremities, most often at C8 to T1, which gives the cape and shawl distribution, with preservation of touch and sensation. Lower motor neuron signs of flaccid paralysis if the anterior horn cells are affected, causing combined sensory and motor defects. Atrophy of hand interossei ulnar nerve. Note that amyotrophic lateral sclerosis, ALS, thenar atrophy can be distinguished from syringomyelia by clinical presentation. ALS patients have motor but not sensory defects. Diagnosis: MRI is diagnostic. Treatment is with Arnold-Chiari malformation. Place shunt to treat hydrocephalus before correction of syrinx, which is posterior fascia decompression, and prognosis is highly variable. Key fact: the patient with syringomyelia classically presents after repeatedly burning their hand on the stove due to loss of pain and temperature sensation. Mnemonic: radial nerve innervates the best. Brachioradialis, extensor, supinator, and triceps. Okay, nice. The best. Brachioradialis, extensor, supinator, and triceps. Okay. Thoracic outlet syndrome, Klumpke palsy, is an embryologic defect in the cervical rib that can result in compression of the subclavian artery and inferior trunk of the brachial plexus, C8T1. Also seen in Pancoast tumors, apical lung tumor, weightlifters. Hypertrophy of the anterior scalene muscle compresses the neurovascular bundle that runs between the anterior and middle scalene muscles, or hyperabduction of the arm, as in falling or breech birth. So these are all thoracic outlet syndromes when you basically compress the subclavian artery and the inferior trunk of the brachial plexus, C8 and T1. Okay, so presentation is thenar and hypothenar eminence, so median and ulnar nerves atrophy. So you're going to have atrophy of the thenar and hyperthenar eminence. You're going to have atrophy of the interosseous muscles due to the ulnar nerve deficit, and you're going to have sensory deficits in the medial side of the forearm and hand. The ulnar nerve, medial cutaneous nerve of the forearm deficits. Disappearance of the radial pulse when the head is rotated towards the opposite side due to compression of the subclavian artery. Diagnosis is history, physical exam, and radiographic imaging demonstrating cervical rib or apical lung mass. Okay. Treatment is anterior scalenectomy, which you have to be careful to avoid the phrenic nerve that runs on the anterior scalene deep to the prevertebral fascia. Surgical removal of cervical rib if present and implicated, and physical therapy. Prognosis: symptoms may return following treatment, secondary to scarring and fibrosis around the nerve roots. Key fact: patients with diabetes mellitus may develop peripheral neuropathy secondary to osmotic damage to Schwann cells. This is the most common cause of peripheral sensory and motor axonopathy. For this reason, it is extremely important to check the feet of diabetic patients. Key fact: toxin-associated peripheral neuropathy results from alcohol abuse, exposure to heavy metals, or diphtheria. Okay. Let me see. Okay, continuing on. Okay, peripheral neuropathy. So now we're going to talk about peripheral neuropathies. So two types occur. You can have demyelination, which often presents segmentally with sensory changes, discrete sensory loss following the distribution of one or more nerves. You can have axonal degradation of motor nerves, presents as muscle fasciculations and atrophy. And you can have axonal degeneration of sensory nerves occurs first. So small fibers are more prone to damage, and it presents with a stocking and glove distribution. Longer fibers are more prone to damage. So hereditary motor and sensory neuropathy. So again, let me rephrase that. Peripheral neuropathy, it presents often with stocking and glove distribution because longer fibers are more prone to damage. Hereditary motion and sensory neuropathy. So hereditary motor and sensory neuropathy, like Charcot-Marie tooth disease, is the most common hereditary neuropathy, autosomal dominant. It primarily affects the peroneal nerve. Onset is typically in the first or second decade. So presentation: peroneal nerve neuropathy leading to atrophy of lower leg muscles. This results in an inverted bottle appearance of the legs. Associated with scoliosis and foot deformities. It's diagnosed with history and physical. Treatment: no therapy to prevent onset or delay of progression. Patients may benefit from physical therapy and surgery for contractures. Prognosis: there is no cure. Progressive peripheral neuropathy. That's sad. Okay, cranial nerve palsy. These cranial nerves arise from their nuclei in the brainstem and course towards their targets, primarily in the face. Muscles of facial expression, gesticulation, autonomic functions, and sensory fibers are supplied by these nerves. Deficits result either when the nucleus or the fibers are damaged and may be bilateral or unilateral. Unilateral defects commonly present with lesions closer to the periphery. Key fact, Lyme disease is the most common cause of bilateral facial nerve paralysis in endemic areas. So now we can have cranial nerve palsies. So one is cranial nerve 3. It presents as oculomotor paralysis. For example, in transtentorial herniation, it leads to denervation of the levator palpebrae muscle, causing ptosis, denervation of the extraocular muscles innervated by cranial nerve 3, causing down and out orientation of the eyes, and interruption of the ophthalmic parasympathetic innervations, leading to internal ophthalmoplegia, which is dilated fixed pupil and impairment in accommodation. Etiology/notes: transtentorial herniation, posterior communicating artery aneurysm, diabetes, Weber syndrome, and brain tumors. Cranial nerve 4. This is extorsion of the eye, weakness of downward gaze, vertical diplopia, worse when looking down, and characteristic compensatory head tilting, aka pseudotorticollis. Cranial nerve 5 motor lesion is a jaw deviates towards the side of the lesion. So if the lesion is at the trigeminal motor nucleus, then it's going to be an ipsilateral loss. If the lesion is higher up in the cortex, then it will be contralateral. Okay. Cranial nerve 7. So this is the facial nerve. So you can get drooping in the corner of the mouth with drooling, loss of buccinator muscle function. You can get difficulty speaking, inability to close eye, loss of taste in the anterior 2/3 of the tongue, the chorda tympani, loss of lacrimation and salivation. You can get peripheral lesions, paralysis of the upper and lower face, central lesions, paralysis of the lower face only. Okay, and that is because of the dual innervation that happens to the forehead area and the upper face. From both sides. So this cranial nerve 7 palsy is seen in AIDS, Lyme disease, sarcoidosis, tumors, and diabetes. Okay, you can have a cranial nerve 10 lesion. This is when the uvula deviates away from the side of the lesion, and it can be resulting from brainstem infarcts. Okay, you can have a cranial nerve 9 lesion, this is a cranial nerve 10 lesion. This is weakness turning head to side contralateral to lesion, shoulder droop on side of lesion. Okay, so this is a sternocleidomastoid contraction, normally moves head to the contralateral side, and you're going to have loss of sternocleidomastoid and trapezius innervation accounts for this presentation. So you can have a cranial nerve 12 lesion, which is lower motor neuron lesion. It's going to be your tongue deviating toward the side of the lesion, aka lick your wounds, and it can be resulting from an anterior spinal artery infarct. Okay, continuing on. Defects in eye movement. So you can have a cranial nerve 3 lesion. This presents with the eye to point down and out. Only the lateral rectus and superior oblique muscles are functional, and dilation of pupil, loss of parasympathetic fibers, and severe ptosis, as opposed to Horner syndrome, which is characterized by mild ptosis. Okay, etiology: the posterior communicating artery aneurysm compresses the nerve, which causes the fixed dilated pupil because of parasympathetic fibers run along the periphery of the nerve bundle. Weber syndrome is a midbrain tegmentum lesion causing ipsilateral cranial nerve 3 palsy and contralateral body hemiplegia. Diabetic cranial nerve 3 palsy involves the ocular motor muscles but spares the pupil because it is ischemic rather than a compressive lesion. Wow, so the diabetic one spares the pupil. Wow. Parasympathetic fibers run on the surface of the nerve, so they are the first to be involved in compression and the last to be involved in ischemia. Ocular motor muscle fibers run along the interior of cranial nerve 3. Wow. That is really cool. Mass effect: brain tumor or epidural hematoma can lead to herniation of the brain tissue with compression of cranial nerve 3. Diagnosis is physical exam, and treatment is treating the underlying etiology. Prognosis is dependent on etiology. Okay, key fact: fibers to the upper facial muscles receive bilateral corticobulbar innervation, which explains why upper motor lesions of cranial nerve 7 present only with lower face paralysis. Fibers to the lower facial muscles are only innervated by the contralateral cortex. Okay, and then you can have a cranial nerve 4 lesion. This is the eye rotated superiorly and lateral because of unopposed action of the inferior oblique. Its etiology is commonly due to head trauma, brain tumors, or increased intracranial pressure resulting in nerve compression. Diagnosis is physical exam, imaging to detect underlying cause. Treatment is directed at the underlying etiology when possible, and the prognosis is dependent on etiology. You can also have a key fact, trigeminal neuralgia, also called tic douloureux. It presents a severe stabbing pain in the sensory distribution of cranial nerve 5. Key fact, cranial nerve 4, the trochlear nerve, is the only cranial nerve to exit the brainstem dorsally and cross the midline. Therefore, a lesion at the nucleus results in the contralateral eye deviating superiorly and laterally. Key fact, cavernous sinus syndrome results from internal carotid aneurysm mass effect that presents as ophthalmoplegia and ophthalmic and maxillary sensory loss, cranial nerve V1 and V2. Key fact, signs suggestive of brainstem lesions, vertigo, cranial nerve 8, diplopia, cranial nerve 3, 4, 6, ataxia, cerebellar, perioral numbness, cranial nerve 5, loss of consciousness, reticular activating system. Okay. Okay, continuing on, cranial nerve 6 lesion. This affected eye fails to abduct, so that's the abducens nerve. Unaffected eye develops nystagmus when the patient tries to abduct the affected eye. Etiology is a lesion within the cavernous sinus. ICA aneurysm. The cranial nerve 6 is most susceptible to injury as it runs directly next to the ICA or the pontomedullary junction. Increased intracranial pressure causing a downward shift in the posterior fossa. Diagnosis, physical exam, and imaging. Treatment is watchful waiting or treat the underlying cause if known, and prognosis, most cases resolve within 6 months. Key fact, Argyll-Robertson pupil is seen in tertiary syphilis, systemic lupus erythematous, and diabetes mellitus. Its accommodation to near objects is intact, but the pupil does not react to light by constricting. Okay. Okay, facial lesions. Upper motor neuron lesion with a motor cortex or connection between the cortex and the facial nucleus results in contralateral paralysis of the lower face only, while the lower motor neuron lesion is ipsilateral paralysis of the upper and lower face. Okay. Mnemonic, Argyll-Robertson pupil is seen in the 3 S's: syphilis, systemic lupus erythematous, and sugar, aka diabetes. Okay. That's a good mnemonic. Okay, visual field defects. Lesions occurring anywhere from the retina to the visual cortex result in the defects in the visual field. The specific intervention depends on the underlying cause and whether the lesion is a severe tract or a parenchymal injury. Uveitis, the uveal tract or uvea is the darkly pigmented and vascular middle layer of the eye. The uvea is composed of 3 layers from anterior to posterior: the iris, the ciliary body, and the choroid. So iris, ciliary body here, and then the choroid. Okay. Iridocyclitis is anterior uveitis plus inflammation of the adjacent ciliary body. Posterior uveitis, choroiditis, and retinitis is inflammation of the posterior uvea composed of choroid. The retina, while possibly involved, is not part of the uvea. Presentation, you'll have blurry vision resulting from inflammation of the iris, ciliary body, and choroids, and may present with retinal detachment and or acute glaucoma. May have hypopyon, accumulation of pus in the anterior chamber, and or conjunctival infection. It's associated with autoinflammatory disease like ankylosing spondylitis, Reiter syndrome, sarcoidosis, and ulcerative colitis. And infection is toxoplasmosis, cytomegalovirus, toxocariasis, which is in ocular larval migrans, histoplasmosis, and tuberculosis, and syphilis. Okay, key fact, Marcus Gunn pupil results from a deficit in the afferent light reflex pathway, for example, a cranial nerve 2 lesion. Retinal detachment. The affected pupil appears to expand when light is switched from the unaffected eye to the affected eye. Pupil is actually returning to baseline from a constricted state. It's diagnosed by swinging a light from pupil to pupil, usually seen in the context of multiple sclerosis. So again, this is a deficit in the afferent light reflex pathway. So the affected pupil appears to expand when light is switched from the unaffected eye to the affected eye. So the pupil is actually returning to baseline from a constricted state. Okay, got you. Key fact, xerophthalmia, dry eyes, may be caused by a vitamin A deficiency, desquamation of conjunctival cells, or Sjogren's syndrome, which is keratoconjunctivitis sicca. Key fact, macular degeneration occurs with secondary to so macular degeneration occurs secondary to disruption of the retinal membrane, leading to a slow onset loss of central vision with preserved peripheral vision, most common cause of premature vision loss in the elderly. Key fact: cataracts, opacification of lens are seen in the elderly and those with diabetes, mellitus, rubella, and corticosteroid usage. Okay, you can also have internuclear ophthalmoplegia, which is medial longitudinal fasciculus syndrome. This is a lesion of the medial longitudinal fasciculus resulting in ipsilateral medial rectus palsy on attempted lateral gaze. This lesion is distinguished from cranial nerve 3 palsy by preserved convergence, in contrast to the down and out appearance of a cranial nerve 3 palsy. Most common cause is multiple sclerosis. Presentation: when the affected eye is adducting, nystagmus is seen on the abducting opposite eye. Normal convergence, finger to nose eye test, but loss of conjugate gaze. In patients with MS, internuclear ophthalmoplegia results from demyelination of the MLF. Diagnosis: clinical. If bilateral, high suspicion of the MS is the cause, you need to exclude myasthenia gravis in patients with isolated medial rectus palsy. Treatment is underlying condition needs to be managed for medial longitudinal fasciculus syndrome. Key fact: amauris fugax is a sudden but transient loss of vision of one or both eyes, often vascular etiology due to embolization of the atheromatous plaque material to the ophthalmic artery, associated with carotid bruit and atherosclerosis. Classic visual sign of transient ischemic attack, TIA, ischemia of the eye, that presents like a shade being pulled over the eye. Clinical correlation: an MLF lesion is on the same side as the eye that does not adduct. Okay. Next, central nervous system infections. So you can have infections that arise in the CNS. They can be divided into those that affect immunocompetent individuals and those that affect immunocompromised individuals, with some specific exceptions. AIDS-defining lesions like fungal, JC viral infection, and Mycobacterium tuberculosis typically occur in immunocompromised patients, and there's a table for these, okay? Key fact: glaucoma develops as a result of increased intraocular pressure that leads to optic nerve atrophy. Increased intraocular pressure may be a consequence of decreased flow of aqueous humor through the canal of Schlemm, with or without narrowing of the anterior chamber angle. Meningitis: inflammation of the pia mater covering the brain may be bacterial, viral, or fungal in origin, usually occurs secondary to hematogenous spread. Herniation syndromes: under increased intracranial pressure, portions of the brain are displaced through openings of the dura partitions or into openings of the skull, for example, the foramen magnum. Therefore, treatment is aimed at removing the insult that generated the increased pressure, for example, a shunt for hydrocephalus, control of intracranial hemorrhage. Treat with hyperosmotic therapy such as mannitol or hypertonic saline. Can use dexamethasone to mitigate cerebral edema to reduce ICP if that is the underlying cause. Okay, and let's read this figure. So a clinical exam for medial longitudinal fasciculus syndrome. So when looking left, the left nucleus of the cranial nerve 6 fires, which contracts the left lateral rectus and stimulates the contralateral nucleus of cranial nerve 3 via the right MLF to contract the right medial rectus. And then, so here is, if your gaze is going this way, so this is a left internuclear ophthalmoplegia. So if your gaze is going this way, this left eye is not going to move because the medial rectus is damaged. There's a palsy of it. If you have a right internuclear ophthalmoplegia, well, you can look this way with the left eye, but the right eye, it's not going to be able to. And it's going to have impaired adduction, and you're going to have nystagmus on this eye, okay? Question: a 72-year-old woman presents for follow-up. She has recently discovered an aneurysm in the cavernous portion of the internal carotid artery. Which cranial nerve is most likely to be damaged first by this lesion? I think it's abducens nerve, because it's going to be loose, it's not attached. Abducens nerve. Cranial nerves of the cavernous sinus include cranial nerve 3, 4, V1, V2, and 6. All run within the cavernous sinus wall except cranial nerve 6, which runs within the sinus itself. Okay, awesome. And we're so close. We are so close to the pharmacology section. Just a little bit more. Okay. Here's another. This is showing the pathway of the conjugate horizontal gaze. Okay, so, and then again, remember PPRF is paramedian pontine reticular formation. Okay. There's a lot going on here. So if the left eye and right eye are supposed to look this way, the thing that helps them keep in sync is this PPRF and then the medial longitudinal fasciculus. Over here, the MLF. So if you have a problem with this, then your left eye is not going to adduct when your right eye abducts. Yeah. Okay. Cingulate. Oh, sorry, let me read this. Key fact, lens dislocation is seen in homocystinuria, and it's going to be inferior lens dislocation, Marfan syndrome, superior lens dislocation, and Alport syndrome, which is glomerulonephritis with blindness and deafness. Optic neuritis is inflammation of cranial nerve 2. It results in loss of vision and Marcus Gunn pupil, and it causes include multiple sclerosis and methyl alcohol methanol poisoning. Okay. Uncle. Okay. Uncle. So this is definition and epidemiology. The uncus of the medial temporal lobe compresses the crus cerebri by herniating through the tentorium cerebri. Results from a mass lesion that forces the medial aspect of the temporal lobe under the tentorium cerebri. So it presents as a stretching/compression of cranial nerve 3, leads to ipsilateral dilated pupil, ptosis, oculomotor dysfunction. So loss of pupillary light reflex proceeds to loss of motor function. You're going to have compression of the ipsilateral posterior cerebral artery leading to contralateral homonymous hymenopia secondary to hemorrhagic infarct of the occipital lobe. You're going to have compression of the ipsilateral crus cerebri, the lateral corticospinal tract leading to contralateral paresis. Compression of the contralateral crus cerebri, lateral corticospinal tract, Kernohan notch leading to ipsilateral paresis, aka a false localizing sign. And you're going to have caudal displacement of the brainstem, compression of the midbrain leading to Druet hemorrhages, paramedian artery rupture, and midbrain hemorrhage. Cerebellar tonsillar. This is herniation of the cerebellar tonsil into the foramen magnum, resulting in cardiorespiratory arrest and or coma by compression of the medulla. Okay, and then here's central nervous system infections according to type of microbe. Okay, so viral, so acute presentation is usually caused by enterovirus, and it's the most common cause of aseptic meningitis. Acute or subacute can be herpes encephalitis, and subacute to chronic viral is progressive multifocal leukoencephalopathy, which is JC virus, or subacute sclerosing panencephalitis, which is measles. Bacterial meningitis less than 1 month is group B, Streptococcus, Escherichia E. coli, or Listeria. 1 month to 18 years is going to be Neisseria meningitidis. Greater than 18 years is Streptococcus pneumoniae. And immunocompromised bacterial meningitis is going to be Mycobacteria. So if it's greater than 18 years presentation, of the person, okay, it's going to be Streptococcus pneumoniae. If the person is immunocompromised, it's going to be Mycobacterium tuberculosis, which is a complication of primary TB. If the person had liver renal disease or aseptic meningitis, like Wales syndrome, you're going to have Leptospira interrogans. Okay? Fungal. So this is so if you're immunocompromised, it's going to be a subacute meningitis, and it's going to be due to Cryptococcus neoformans. If you have diabetic ketoacidosis or leukemia, it's going to be mucormycosis. Okay, which is mucor or rhizopus fungus. Okay? Parasitic, if it's rapidly fatal, and the person is immune competent, it's going to be the brain-eating parasite Naegleria fowleri. If it's rapidly fatal and it's immunocompromised, it's going to be Acantha moeba. If it's neurocysticercosis, it's going to be Taenia solium. If you have AIDS, it's going to be Toxoplasma gondii. And if it's going to be malaria with the central nervous system infection, it's going to be Plasmodium falciparum. Brain abscesses, if you're going to have them bacterial, they're going to be Streptococci, Staph aureus, Enterobacteriae, Bacillus fragilis, or Peptostreptococcus. Helminthic brain abscess is going to be Taenia solium, schistosoma, or hydatid cyst, which is Echinococcus granulosus. Okay? And then transtentorial herniation can result in coma and death due to the brainstem ischemia from compression of the brainstem and shearing of the basilar artery perforators, leading to brainstem hemorrhages, Durette hemorrhages. And then we have types of cerebral herniation. So A is the cingulate subfalcine herniation. B is a central transtentorial herniation. C is an uncal herniation. And D is cerebellar tonsil herniation. Okay? Headache syndromes. A patient presenting with headache is the primary complaint, has a broad differential. Common headache syndromes are presented below. Migraine, tension type, and cluster headaches are used. Primarily clinical diagnosis based on history and physical exam. However, secondary causes of headache should be considered, including subarachnoid hemorrhage, meningitis, neoplasia, hydrocephalus, and giant cell temporal arteritis. Okay, migraines. So a migraine headache is usually recurrent in nature and commonly presents in unilateral, pulsatile throbbing pain associated with nausea, vomiting, photophobia, and phonophobia. It may be precipitated by a trigger like stress, menstruation, visual stimuli, or other factors. Episodes typically last 4 to 72 hours and may be aggravated by routine physical activity. Classic migraines include an aura, whereas common migraines are not associated with an aura. These headaches are thought to be due to irritation of the trigeminal nerve, meninges, or blood vessels. They release of vasoactive peptides like substance P and or calcitonin, gene-related peptide. Treatment is abortive. Pharmacotherapy should only be taken if the person is actively experiencing a migraine and includes non-steroidal anti-inflammatory drugs, aka NSAIDs, acetaminophen, and triptans, like 5-hydroxytryptamine, 5-HT agonists. Better results are usually achieved when medications are started as soon as symptoms appear. Prophylaxis for migraine headaches includes beta blockers, metoprolol, propranolol, and timolol, antidepressants like amitriptyline, anticonvulsants like topiramate and valproate, and calcium channel blockers like flunarizine and verapamil. Tension type headaches. Tension type headache is the most common headache in the general population. They present as constant bilateral pain, often in a band-like distribution. Unlike migraine headaches, they are not associated with photophobia, phonophobia, or an aura. They last at least 30 minutes, but typically resolve in 4 to 6 hours. Treatment is analgesics, primarily NSAIDs or acetaminophen. Amitriptyline can be used as preventative treatment. Then you can also have cluster headaches. It presents as unilateral, severe periorbital pain. Compared this to tension type headache, which was bilateral. So the cluster headache is severe unilateral periorbital pain associated with unilateral autonomic manifestations such as lacrimation, rhinorrhea, conjunctival infection, and partial Horner syndrome, ptosis, and meiosis. They usually occur in males and are more common in young smokers. They often occur daily for a period of weeks, followed by a period of remission, hence the term cluster. Treatment, 100% supplemental O2 should be the first abortive therapy attempted, then sumatriptan is first-line pharmacotherapy for abortive therapy, and verapamil is first-line pharmacotherapy for prevention. Trigeminal neuralgia presents as a repetitive unilateral shooting pain in the distribution of one or more of the branches of the trigeminal nerve, so V1, V2, or V3. Pain usually lasts a few seconds per episode versus cluster headache and is often described as electric, shock-like, or stabbing. Trigeminal neuralgia is more common in women, so cluster is more for men. Trigeminal neuralgia is more for women. Most cases are believed to be caused by compression of the trigeminal nerve root by an aberrant loop of an artery or vein. Causes of secondary trigeminal neuralgia include herpes zoster, multiple sclerosis, and space-occupying lesions. Diagnosis is clinical diagnosis based on history and physical exam. Neuroimaging, MRI or CT, is commonly performed to distinguish between classical and secondary trigeminal neuralgia. And treatment is the first-line medical treatment for classic trigeminal neuralgia is carbamazepine. In cases refractory to medical management, surgery is often warranted. Okay. Wow. We made it all the way to pharmacotherapies. Okay. Oh man, that was a lot. Let me pause. Okay, so if I kept going with pharmacotherapies, which I don't think I will, because I don't think this is the best way to learn drugs through this would just take me from page 507 all the way to all the way to 532. Oh, that's way too long. Yeah, no. And what if I did psychiatric? Oh, they don't even have psychiatric form. So psychiatric is actually, look, it doesn't even look like that much. Like only 30 something pages. Okay. Let me scroll back up. I think I'm going to do the first aid abstract notes, but first I really need to take a break. So I'm going to take a break. Let me see. Okay, so that's where we are right now. How do I stream settings? Maybe no. Stream health. Stream is healthy. Let's pause it on OBS. I could stop streaming. Let me just say break. Hello. Oh wow, so OBS is not stopping actually the transmission of my audio mixer, even if I... Interesting. I guess I have to stop streaming.